Welcome back to the OurView Podcast. This episode is part of our Mental Health Monday series. These episodes will highlight topics related to mental health. The episodes will sometimes share the stories of those who have been medically diagnosed with mental health disorders, and other episodes in the series will share interviews with mental health professionals who will provide an overview of the different types of mental health diagnoses and their treatment options. These episodes are intended to be informational and educational only. It is not medical advice, and any information within these episodes is not intended to diagnose. We encourage you to always seek the guidance of your medical physician or clinician for any decisions regarding your medical needs and conditions. On today's episode of the OurView Podcast, I welcome my guest, Dr. Owen Muir. Join our conversation as we discuss clinical depression. So now I would like to officially welcome Owen Muir to the OurView Podcast. This is the first episode of our Mental Health Monday series, where we will be highlighting topics related to mental health. So on this episode, Owen and I will cover the topic of depression. And Owen, can you just explain to our listeners who you are and tell us a little bit about yourself and what you do and all that kind of good stuff?
Sure. My name is Owen Muir, MD. I am a child, adolescent, and adult psychiatrist. I received my medical degree from the University of Rochester School of Medicine and Dentistry, home of the biopsychosocial model of medicine, which should be used everywhere, not just psychiatry. I did my adult residency training at the Zucker Hillside Hospital, part of the Northwell Health System out in Long Island, and then did child psychiatry fellowship at the NYU Bellevue program, which is the Navy SEALs of child psychiatry. And then I co-founded Brooklyn Minds with Carlene McMillan, who is also my wife and the other best psychiatrist I know. But I come to this not just as the Hair Club president, but also as a member. I have bipolar disorder, and part of that is having experienced depression in my life in ways that sucked. However, they really did a very good job of letting me understand what my patients were going through, and it's a little bit of a cheat code because I kind of have the secret manual for like what it's like, and so the questions I'm able to ask are a little bit more effortless than the effort that goes into kind of learning the ins and outs of the experience of someone with OCD, for example, which I deal with all the time, but don't personally have the experience of.
Mm-hmm. Wow, that's great. I love the other best psychiatrist is your wife. That's great.
I got really lucky.
That was really great. Made me laugh. So again, thank you for connecting with me. You and we connected through the new Clubhouse app, and we were in rooms together, and I reached out to you, and you were gracious enough to agree to do this episode with me. So again, this topic we're covering now is for depression. So can you explain what clinical depression is and how is it diagnosed?
Sure. I want to start out by saying not all feeling bad is depression, and not all depression is feeling bad.
That's good. That's really good.
There are many ways to be miserable, and some of them you can have happen all at once. When I think about major depressive disorder, which is a defined clinical entity, I start out with a good dose of uncertainty. One of my patients did a remarkable job of creating the kind of example of what I'm talking about. As an art project, he took the 764 ways you can combine the criteria for depression and still get major depressive disorder. And he made an algorithm that created each of them as their own separate diagnosis in DSM format, and then printed an 8-volume set called the DSM-5 Exhaustive Edition, The Major Depressive Disorders volumes 1 through 8. And he was kind enough to give me volume 6 after it won the APA Art Show second prize. And what I thought was so important about that is it highlighted how arbitrary our approach has been. And major depressive disorder, which you'd think psychiatrists would agree on, actually has the worst, what we call inter-rater reliability, aka 2 expert research psychiatrists seeing the same person on the same day. They will agree only slightly more often than chance as to whether that person meets criteria for major depressive disorder.
Wow.
56% of the time they'll be on the money. So it's the least reliable in terms of inter-rater reliability diagnosis in the whole book.
Yeah. So,
And yet it's still definitely a thing.
mm-hmm.
Right? Not all
Yeah.
things that are true are in the book. Not all things that are in the book are true. And so is this a helpful diagnosis? I don't really like the word label, but is the label we have for this helpful? And I'd say at this point, yeah, to a point.
Mm-hmm.
But I think it's really important. Most people who come to see me, and if I have to hear one more health tech startup talk about depression, anxiety in that kind of one word, no pause kind of way, and just totally not acknowledge there's any other suffering in the human condition that might come their way, I'm going to lose it.
Yeah.
So mostly what happens, depression is a way people can say, I feel bad, and go see a psychiatrist. And if the psychiatrist is savvy, they might actually get an explanation for what's really going on. And if they're not, they're going to get a prescription for a medicine and probably suffer for many years with something that isn't accurate or is incomplete or doesn't offer any understanding
Mm-hmm.
of what might be going on. That having been said, major depressive disorder, to answer your question, what is it? It is a mood disorder, which means it's episodic. It's there sometimes and not others. How long that is can vary, and some people can have it for many, many years. But the idea is this is a difference in your mood, and you meet the DSM, the Diagnostic and Statistical Manual for the Diagnosis of Mental Disorders, which is the major product of the American Psychiatric Association and decided on by a bunch of politicians, literally. They have every disorder kind of in the same format. There's A criteria, which you have to have, B criteria, which you have to have some number of, and it has to cause clinically significant impairment, which is C, and then D, it can't be better explained by other stuff. And in the case of major depressive disorder, and this is what I meant by not all feeling, bad is depression, not all depression is feeling bad. For the A criteria, you can have either depressed mood or there's a word from the Greek helpfully put in to make sure no one understands what they're reading, anhedonia, the inability to experience pleasure. Take hedonist, hedon,
Right.
and put not an in front of it, anhedonia. And you can have either depressed mood or anhedonia or both as the A criteria for major depressive disorder. So there's some people who are suffering from it who aren't depressed. And so what most psychiatrists do is they learn the checklist, SIGI caps. Seriously. So is there disturbed sleep, insomnia? Sometimes it's early insomnia, falling asleep. Sometimes it's waking up early, restless throughout the night. Is it a decreased interest, aka anhedonia, in things that would normally be fun or pleasurable? Do they feel guilty or worthless? Do they have low energy? Do they have a poor concentration? Is their appetite either increased or decreased by a significant amount? Has there been weight gain or weight loss that people didn't plan on? And finally, are there thoughts of death, dying, or suicide? And those are the criteria for major depressive disorder. And put them together 764 ways, it's still depression. And just because you have that major depressive episode doesn't mean you have major depressive disorder, because that can come with bipolar disorder. It can come with major depressive disorder. It can come with other things as well. But that's what an episode of depression is defined as, somewhat arbitrarily based on a checklist someone made and they decided was good enough before DSM-3. And that's how we do it now, which turns out to be highly unreliable.
Right. Because it goes back to what you said, that, it doesn't always look sad. It doesn't always look, like I've been in bed, and there are many people who experience this, and they still go out, they go to work, and they still, you know, go do things with their family and friends and their kids. And it's,
Let's say you're one of the
everything's different.
10-year-olds at Bellevue I worked with who's Black. For
Mhm.
him, it looked like anger and aggression, and he was brought into the emergency room for that. Right?
Right.
Let's say you're, old, it can look like dementia. It can actually
Hmm.
impact your brain to the point you're demented. For some people, it can be just catatonic impairment, and some people can go through the day and look just fine until they're dead by suicide.
Right. And it's really every, I say it all the time, even about with my physical disability of having spina bifida, that every person is different. And it really it can really span the spectrum of, like you said, from anger to looking like it's dementia to someone that doesn't get out of bed for, a couple days or a couple weeks. So I think it's very, very important that we are discussing this and bringing it up. So you mentioned, part of the criteria, the A, B, and C, and um, is there a certain time length that these symptoms have to be shown, or?
2 weeks is the answer for
Okay.
reasons. So it's 2 weeks, and in bipolar disorder or any length of time if hospitalization is necessary.
Hmm. Okay, yeah. And can you just talk about a little bit about what treatment options are available? I know you're a psychiatrist, and you can prescribe medicines and all of that. So can you just talk about some of the treatment options available for major depressive disorder?
I will. First, I'm going to talk a little bit about the problems with the data we have to determine what those are, just so
Yes.
people understand it, because it's really important.
Hmm.
When we're getting a drug approved for depression, this is actually a conversation I had with my friend who was working in drug development at Pfizer for many years on the brain side. And he was angry. He said, look, psychiatry abdicated its responsibility to cure anybody when we invented SSRIs, because the benchmark for getting an antidepressant medication approved by the FDA became a 50% reduction in symptoms. Do you want to feel 50% less depressed, or would you rather your depression be over?
Hmm. Wow.
Because every drug we have is approved based on 50% less miserable, not better, not well.
Wow.
Furthermore, most people, or many people, are started on an SSRI if they're suicidal, which can often come with depression. And we have close to no studies on medication for suicidal people with depression. So if you're suicidal and you're prescribed Lexapro, Prozac, Zoloft, Paxil, blah, 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 that drug has never been in a study where they admitted people to the study who were suicidal. So it's almost like it's a giant uncontrolled experiment on every suicidal person we give that medicine to.
Wow.
Now, there are good reasons for that, but it's worth knowing, like, we have no data essentially on those medications in people who are suicidal until very recently, when Janssen got the indication, God bless them, for esketamine for major depressive disorder with suicidal ideation, that we did a study specifically on suicidal depressed people. And so it's a little bit like we only ever studied not bad cancer or hypertension that was really mild or whatever it is. Just pick
Hmm.
your disorder. You know, it hurts, but not too bad. Well, let's study every pain medication in people who are like a 3 on the pain scale.
Right. Wow.
And
That
that's what we
is,
did.
yeah.
So there are treatment options, and they have varying degrees of evidence. And the problem is, like, the same time we decided we'd do that with medicine, we decided, why don't we do the same thing with therapy? So let's test it really short term, 8 weeks. Cognitive behavioral therapy is time limited. Great. Can we get a 50% reduction in symptoms there too?
Hmm.
And they got all the study participants from the people who live on the island of one problem. I've never been there. I hear it's very nice because they only all have one problem. But like nobody who comes and sees me has one problem.
Right.
It's depression and OCD and ADHD and an eating disorder and maybe a history of self-injury. Maybe it's a personality disorder. Maybe it's not. We'll find out. Blah, blah, blah. It's this whole like array of problems, which is a word I like better than mental health issues or mental illness. I think problems kind of sums up how people see it.
Mm-hmm.
And is, I think, more consistent with how I understand it. Like, well, what problems do you have? Because,
Right.
you know, they might be, I'm homeless, or they might be, you know, I can't keep down a job or whatever. And there's probably something going on in your brain buried in with those things. But what you understand as a problem might not be depression, especially if, as I mentioned before, you're not even depressed.
Right.
Yeah, I'm not depressed. I just don't want to do anything. I think I'm bored with my job.
Yeah. That's it is. It's very complicated to figure it all out. And like you said, problems, we all have different problems, and it's that is a good way to think about it and to address it.
Which is not to say for some people these things don't work very well.
Mm-hmm.
They do. And it's not to say you shouldn't treat depression or shouldn't try to evaluate it and figure out what's going on. But you should have an understanding that in studies where not so sick people are the only people in the study who've never been exposed to any antidepressant before, and you give them first one antidepressant, the chance of remission of your depression, having it be over, is 30% with that first drug 8 weeks later. And the chance of remission with the second drug, if you don't get to remission with the first, is 10%. And the chance of remission with the third drug you try is 10%. And the chance of remission you have with the fourth drug you have is 10%. And so 2 years and 4 drug trials later, you have a 50% chance of your depression being over.
Wow.
That's from our largest study on depression treatment alternatives called STAR-D, Sequence Treatment Alternatives to Relieve Depression.
Yeah. Well, thank you for that great explanation, because it's, a lot of times you think it's an easy fix sometimes.
I wish.
And and it's just
that's my least of my concern.
Yeah, and it really isn't. It's just but you have to consider that type of scenario where it's not just a person coming to you, like you said, with just one problem.
Mm-hmm.
It's, it's not just I've been in bed for a couple of weeks or I've been feeling sad for a couple of weeks. It's piled on a bunch of other problems on top of that. So you have
there are two ways when you're saying that. There's something in there. When someone
Mm-hmm.
asks you, like, what's wrong? ? It matters if they follow up with, are you feeling feelings of guilt or worthlessness? How about poor energy? Check. Do you have trouble concentrating? Check. You have depression, right? Or they could say, why? Help me understand what's wrong.
Yeah,
it's a different conversation.
Two different conversations, exactly.
Yeah. And you need to have both, practically speaking. But
Mm-hmm.
I think the first conversation is best had embedded in the mind of the person doing the evaluation while they're asking the second question and listening. Those are the basic, like the oral medications. That's what we got.
Mm-hmm.
And it turns out, psychotherapy is awesome. Psychotherapy is awesome for a bunch of reasons, but one of the reasons it's awesome is it works and has sustained effect. And there are a bunch of options that are evidence-based treatments for major depressive disorder, and some that work for that and other things as well. And so you have everything from dynamic, psychodynamic therapy, psychoanalysis, which I'm not a huge fan of, but we have cognitive behavioral therapy for depression, interpersonal therapy, IPT. We have IPSRT if you have bipolar depression, interpersonal social rhythms therapy, a lot of acronyms. They're mostly 3 letters. Every once in a while, you'll get to more. And that's when you've got something real different, right? We got more than 3 letters in your therapy acronym. So we have psychotherapy, and we have what we call somatic interventions on your body. And those include the gold standard electroconvulsive therapy, which is tremendously effective for severe depression, transcranial magnetic stimulation, or TMS, which has some related variants, including deep transcranial magnetic stimulation or DTMS, accelerated intermittent theta burst stimulation, or AI-TBS, aka SAINT, great branding, Stanford Accelerated Intelligent Neuromodulation Treatment. We have ketamine, esketamine, studying other things currently like psilocybin and other psychedelics. There are other treatments than just the pills. And you should understand what your options are from your psychiatrist if you're going to see them. And if you do not understand that you have options, they have not done their job.
Perfectly said. Yes, there are always options. There are always more than one option, and everything is not for everybody. That's I think that's a key thing to mention. So what you heard works for your friend or your relative that has depression may not work for you. So as Owen just said, you have to get your get your doctor to figure out the best treatment plan that is for you. And of course, this episode is strictly about providing information for everybody. We're not, just because you heard something that may apply to you does not mean we're not at all diagnosing you in any kind of way. So
this is not medical advice.
No.
Speak to your physician or clinician for any decisions regarding a medical condition.
So is there anything else that you would like to add to this?
Yeah.
Yes.
I think it's important to understand that there's an experience people have with depression and how that colors their life, whether they're depressed or not. And when people have had depression, first off, often they've been very disappointed because they'll come in for what they hope is an easy fix, and it's not. And the medicine doesn't work as well as they'd hoped, or they're still suffering or whatever. And you just learn to not trust help. When that help is involuntary hospitalization, that can be really, potentially harmful. The completed suicide rate after discharge from the hospital for depression is 2,000% higher than it is for the general population, and remains 30,000% higher for the rest of your life. So it's not that people trip and fall into a hospital, right? But if the hospitals were helpful, those numbers would go the other way. Turns out the locks on the doors, empirically, are almost unimportant. The rate of running away from the hospital, what we call elopement, is the same, whether there are locks on the doors or not. And the rate of completed suicide is higher for people who've been in locked settings. So the locks on the door are for the peace of mind of the psychiatrist, not to keep the patients in.
Wow, those numbers, that's really wild to think about.
Right. Well, we're thinking about can I stop you from killing yourself now? And that's important. But I really want to know if you're not going to kill yourself for a while longer, because stopping you on Tuesday and you do it on Friday doesn't do the world much good.
Right.
And it's not really doing you any favors. And I think we don't have a system that's designed to actually take care of people in the outpatient setting.
Yeah, and so to extend that,
take it seriously.
Yeah, extend that care beyond the hospital stay. Yeah, that's a key thing.
Insanely level. Would you rather go to the hospital involuntarily and sit in an ER all night, not get any sleep, or have someone come over with pizza and talk to you about how you're doing?
Yeah, well, that's when you put it like that, that's really very eye-opening for me, because I had two great visualizations when you said that.
What would it be like if the person who came over with pizza was an EMT, and he could also give you a dose of esketamine, which could work in the first dose to relieve your symptoms? If you're acutely suicidal, if the first line intervention was pizza and esketamine and a conversation. It's cheaper too.
Yeah. Yeah, I just got two great visualizations of that, of which one. Yeah, it's definitely at home and just chilling out. And
it's not a hard question, right? We want to feel less lonely and supported in a crisis. And then we want to be out of that crisis.
Yeah, figuring out how to get out of that crisis is the big thing for sure. Wow.
And to make you even more frustrated, just so you know, what if I were to tell you there's a treatment we have evidence for, randomized controlled trial evidence for, that can get people to remission of their depression in 5 days, even if they've failed on average 13 medications 80% of the time. Stanford Accelerated Intelligent Neuromodulation Treatment, or SAINT, aka AI-TBS, and I do it all the time. 5 days.
This is the kind of information we need to talk about and get out to the larger population of people, because a lot of people, especially after, I know everybody says it all the time, but especially after this last year of being in the house all the time and being away from family and friends, and it's just it's been rough for a lot of people. So
And it has.
yeah.
That's important to recognize. It really has been as rough as you think it is.
Mm-hmm.
And also, sitting around thinking about killing yourself all the time isn't normative.
Right.
You should feel shitty, but there's a difference between feeling shitty and being depressed.
Mm-hmm. Yeah. Big difference. Yeah, for sure. Wow.
So,
Yeah. So thank you again for this.
thank you.
Yeah. Thank you for this great information that you provided. And you will all be hearing from Owen again. We are recording another episode for another topic. So, yeah. So, thank you, Owen, for this time. And I appreciate you. And I will be talking to you soon.
Thank you so much.
All right.